Dear Chairman, dear ladies and gentlemen, it is a great pleasure for me to have some information for you about contrast-enhanced ultrasound for planning, monitoring, and the follow-up after TACE. What would be important? We have to talk a little bit about fusion for planning and for the follow-up. We have to talk about the technique of contrast-enhanced ultrasound, and we have to talk about new kind of evaluation, the treatment success. First time, what means chemoembolization, TACE? We have first time to make a selection of the kind of tumor. Normally, we perform TACE in cases of HCC lesions, and considering the Barcelona classification, it would be the stage B one. The next, what means transarterial embolization? We use catheters, microcatheters. The aim is that we have to identify the feeding tumor vessels and give chemotherapy and embolization materials selective into the tumor center, not in the surrounding tissue. And my opinion would be that contrast-enhanced ultrasound is the best way to use it for the perfect result of a selective chemoembolization. What have we to know about the tumor selection? Tumor selection means TACE is a very good way if you have a tumor in one part of the liver in cases if liver surgery is not possible. It's considering the Barcelona classification, the stage B. Now we have also from literature some cases of successful embolization in a stage C1, but normally we use it for the stage B. The next, what is important for you? You can use for planning the MRI. You have a localization of the tumor in the case of a HCC. But if you use contrast-enhanced ultrasound, you have an excellent view over the tumor microvascularization. And this is so important that you know the dynamic vascularization in the early phase of arterial contrast enhancement. After look at this 20 seconds, and so you have a better view for segment and for the vascularization, and you could make an excellent planning of the treatment. For you, what means contrast-enhanced ultrasound? Normally, we use a second-generation contrast agent. We don't use so much contrast agent like we for CT or MRI. For TACE monitoring, you only need up to 0.5 milliliters of contrast agent. Normally, I use sonory. You have to reduce the energy for your ultrasound machine. You have performed contrast imaging using pulse inversion harmonic imaging. And it would be important that you have a possibility to make a storage of DICOM loops and the possibility to connect to a PACS. Look at this for the excellent paper from our chairman considering the EFSUMB guidelines. The next very important information for you. What about tumor microvascularization? Look at this comparison between contrast-enhanced ultrasound and MRI. Only using contrast-enhanced ultrasound, you have an information about the early hypervascularization and the mean diameter of the tumor lesions in cases of HCC lesions. This is so very important because in this case, there was a decision from MRI that embolization should not be happen. But from CEUS, you see the hypervascularization, and we could perform a successful treatment using TACE. What we have to discuss it is normally the liver contrast enhanced imaging is a level use, but to use this for TACE is an off-level use, but it is very useful for our patient. And so if you are an experienced examiner, use it and help our patient. What we have to learn, look at this. It is not enough to plan TACE using the B mode. From B mode, it seems to be an HCC at the size of 4 centimeters. But if you use high resolution contrast, you could see it is a very, very enlarged tumor, and you have a view over the tumor microvascularization like you normally could see it with a microcressida from intraarterial DSM. This is so high resolution with intravenous contrast agent. Look at this, the next step. We have to use new technologies like tumor perfusion imaging and color-coded imaging. You have an excellent view over the feeding tumor vessels and could plan in which side you should perform the embolization. On the next step, what means characterization HCC lesions? Early arterial irregular hypervascularization at a very important criteria. But look at this in the late phase after 3 minutes, you have to look for the washout criteria, irregular hypervascularization and washout in the late phase for malignancy. What have we to learn? Using contrast-enhanced ultrasound, we have a dynamic evaluation from tumor vessels for the early arterial phase continuously up to the late phase to 5 minutes. This is not possible to use the MRI and CT scan. And so I think it is the best way for planning interventional procedures like chemoembolization, because using contrast-enhanced ultrasound, you have this kind of continuously tumor microvascularization. The next step for me and my team and research, what should we have a possibility to evaluate what means tumor vascularization for malignant tumors, and look at this using a new combination of contrast-enhanced ultrasound and color-coded perfusion imaging. You could evaluate parameters for perfusion of malignant lesions like time to peak, the volume flow, and the blood volume inside of this kind of malignant tumors, and we could find significantly difference between benign and malignant lesions. But we have not only visible the contrast enhancement, we have a possibility for quantification, and this is so important. If you ask me, are we sure that we could find all HCC lesions? Are we sure that we could characterize HCC lesions? And are we sure for very good characterization and localization of tumor vessels? So I have to answer, in comparison to MRI and CT scan, we have a high diagnostic accuracy for contrast-enhanced ultrasound. The diagnostic accuracy is over 90%, and this is excellent. What means now treatment using contrast-enhanced ultrasound for chemoembolization? First time is localization of the tumor, placement of the catheter near the tumor, microcatheter. The next step would be to give chemotherapy inside of the HCC. The next step would be now the combination of chemotherapy with embolization. And finally, we will hope that we could find a devascularization of the HCC. Now look at the next steps. What means before for planning contrast enhanced guidance of TACE? I use fusion. I use fusion between CEUS and CT or MRI, but look at this. We have an excellent visualization after one part of embolization. we find also new vascularization at the margin of this tumor lesion. And we could see the dynamic using fusion between MRI and CEUS. The next step is now we have an exactly view over the segment of the HCC lesion. We know which are the tumor vessels and how we have to embolize this to reach a complete devascularization in this case. And this is the advantage of CEUS for planning, monitoring, and follow-up of TACE. We have 3 different kinds of TACE. Many years before, the beginning was to use lipiodol with cisplatin. Now we use drug-diluting beads for a new kind of embolization, but we optimized also in combination with CEUS the TACE using Embocept, a chemoperfusion. Look at this. The first step is that you prepare the injection for embolization and for the chemotherapy. In this case, you have a very difficult case in 3 tumor lesions. And the aim was that you use lipiodol for excellent selective embolization of all these tumor lesions in combination with monitoring using contrast-enhanced ultrasound. And it has happened excellent. Look at this fusion after this embolization. In all the 3 localizations, you have a complete devascularization of the HCC lesions, and you have no complication. You have no infarction of the liver. It was a very difficult treatment, but it happened excellent using contrast-enhanced ultrasound for monitoring. The next step is, if operation is no more possible, look at this part. You have a resection of the right part of the liver, but we have a new HCC lesion near the vena cava. For planning, we used contrast-enhanced ultrasound. For guidance, we use it. And then we could realize a very, very difficult embolization, but look at this, it is a complete devascularization of the HCC and no complication. Means the message would be that we have an excellent tool for difficult treatments. The next step is, could we see it only using our eyes, or do we have a new technology for evaluation of success? Evaluation of success, look at this. In this case, in HCC-B4 in red and yellow colors, you could quantify the hypervascularization using perfusion imaging. And afterwards, if you perform an excellent devascularization, no red and yellow color in this perfusion quantification, you have an excellent result, color-coded as a blue one, complete devascularization. The next step for me and my team was that we modify TACE. We use now contrast-enhanced ultrasound by the microcatheter and using intraarterial contrast-enhanced ultrasound. We have a new way for exactly placement of beads for embolization, complete devascularization also for bigger HCC lesions. The next step would be, if we have bigger HCC lesions, we need more information about vascularization, not only in the center of the tumor lesion, also quantification, what happens surround of the tumor, where are the tumor spreading vessels. And we have a quantification also with curve analysis. Look at this in the green one, curve analysis of the HCC, you have a irregular, very strongly hyper enhancement. And after selective TACE, look at this, the green line, now it's near 0. We have a completely devascularization if we use contrast-enhanced ultrasound, intraarterial for monitoring of a TACE. And the next step would be for the follow-up. If you have a devascularization, look at the HCC before, you have an irregular hyper enhancement of the tumor in red colors, and afterwards you have a complete devascularization, and you could use perfusion imaging for very precisely follow-up. It is helpful for very difficult cases. Look at this, a very, very big tumor on segment 8. We could reach using chemoperfusion for complete devascularization. And I think first time all over the world, we use a combination with fusion imaging, not only for blending. We use intraarterial CEUS for optimizing chemoperfusion also in bigger HCC lesion, diameter more than 5 centimeters. And we have a very successful treatment also in this cases. Look at this for the follow-up. Before you have an irregular hyperenhancement, yellow and red colors curved with strongly enhancement, and afterwards it seems to be that we have a completely devascularization also for bigger tumors. So in our research, look at this, if we use perfusion imaging for quantification, we have excellent, significantly results for this kind of intraarterial CEUS for monitoring TACE, for reduction of peak enhancements of the tumor, for wash-in area under the curve, and wash-in rate. Means we could quantify our success and use these parameters also for the follow-up. The next and last step at this time for our team would be that we use a new external quantification software for the DICOM loops, and you could use it for quantify HCC lesion for time to peak, mean transit time, rise time, washout rate before treatments, and for the follow-up, look at this green line and yellow line after successful treatment. You have a devascularization of the tumor vessels. It means we could show that we have significantly difference for mean transit time, for peak enhancement, wash-in rate, if we are successful. And we have significantly difference if we know it is a completely devascularization, or we have a little bit tumors at the margin of the treatment lesion. So we use this parameter for more precisely follow-up. And look at this in conclusion. I think for you, the best information is if you look for the contraindication. You have many contraindication for contrast agents from the CT scan and MRI. But using contrast-enhanced ultrasound, you have an excellent tool in combination with intraarterial tumor application and TACE for reach a complete devascularization of the tumors. And so I think in conclusion for you, the best information would be that we use this high resolution technique in combination with fusion and perfusion imaging for very good treatments. Also in difficult cases, we could help our patient, and you could perform excellent treatments in situation where our patient asked you, is it possible to help me? And do you know for an excellent imaging for treatment? And so I have to say thank you for your attention for this first discussion about new ways, but we are together on an excellent way to help our patient.
Thank you, Michael, for a very comprehensive overview of using CEUS and TACE. Can I just ask you one quick question? What doses are you using when you inject intraarterially?
You need very less contrast agent. We use the sulfur hexafluoride microbubbles. It's called Sonori, and you use less than 0.5 milliliters by the microcatheter. Often it is enough that you use 0.2 up to 0.3 milliliters. And this is very excellent because you could see the tumor spreading vessels, and you could very use it in combination with intravenous contrast agent. First time you give an intravenous contrast injection up to 2.4 milliliters. Then you are waiting for the washout of the HCC lesions. And if the placement of the microcatheter is in a very good way, if you then give intraarterial CEUS, then you have the mask from washout and the filling by the microcatheter inside of the area of washout, and you could be sure that you have the best way for treatment.
Okay, and do you dilute the contrast when you inject it arterially? The volume is so small. Do you make a bigger volume by adding saline?
Now, you have, if you give it intravenously, you know, we followed by, I use 10 milliliters saline solution afterwards, but in the microcatheter, you only make injections at maximum. You give at maximum 0.5 milliliters contrast agent, and in maximum, you give an injection up to 1 milliliter in combination with NaCl with saline solution. Don't give more than 1 milliliter inside of the microcatheter.
Okay, that's a very good practical tip. Thank you very much, Michael.